Next on Primary Care, the maternal health crisis, why Black mothers and babies continue to face higher risks.
The more we can do to help them not just have a healthy pregnancy, but to be in the best condition possible when the pregnancy is over to continue care, the better the outcomes are going to be.
Hello, I'm Dr. Lonnie and welcome to Primary Care, the show dedicated to improving the health and care of African Americans. Pregnancy should be a time of hope and anticipation, but for many Black women, it can also come with serious risk. In the United States, Black mothers are 3 to 4 times more likely to die from pregnancy-related complications than white women. And here in Michigan, the gap is even wider. Black women face significantly higher maternal death rates, and Black infants are more than twice as likely to die before their first birthday. What makes this crisis even more troubling is that many of these deaths are preventable. Experts say that causes range from chronic health conditions and delayed prenatal care to stress, social factors, and bias within the healthcare system. Joining us today is Dr. Theodore Jones. Dr. Jones is Director of Maternal Fetal Medicine at Corewell Health. He is also Chairman of the Michigan State Medical Society Task Force for Advancing Health Equity and Associate Professor at Wayne State University School of Medicine. Ted, welcome to the show. So glad to have you.
My pleasure being here.
Good. Ted, the Black women are several times more likely to die from pregnancy-related disorders or complications. What does that mean for us here in Detroit? How do these statistics apply to Detroit?
It applies to every woman of color in the Southeast Michigan area. Mm-hmm. They all have a built-in hedge against their success, and it relates to a lot of things related to the way our health system works. There is what we call racism that is part of the structure, or structural racism. There are encounters that they've had in the past with healthcare providers that were really not positive encounters. That together with stress in their lives and difficulties in terms of making sure that people are hearing them makes it difficult for pregnant persons to really embrace prenatal care and to show up. And therefore, we understand that we will not be able to have the full care that they need because of that.
I'm reminded of the Serena Williams incident a couple years ago with her pregnancy. So despite of having education, good jobs, health insurance, we still see this disparity.
We do, and much of it has to do with our tendency to not always be in focus with the patient's needs. Our patients have needs that go beyond that immediate medical care. Mm-hmm. And so we oftentimes talk about what is sometimes referred to as social determinants of health. But that's kind of a fancy way of saying that people who are really dealing with poverty and indigency in their lives struggle. And they struggle with their existing family, they struggle with their own personal psychological outlook. All of those things start to weigh heavily on them. And therefore, it really makes it necessary for us to think about the patient more than just that diagnosis of hypertension, but who that person is beyond that.
Mm-hmm. So these things have an effect on the mother, on the baby,
yes,
more so than populations that don't suffer these disparities.
Correct. And it's something that also has not just happened to this one person. Mm-hmm. And so we're much more aware of the fact that this is a legacy of families. Mm-hmm. So you have what we sometimes call generational trauma or intergenerational trauma, where you have relatives and you have parents and grandparents who had relationships with healthcare that weren't positive. Mm-hmm. And so they tend to have aversion kind of behavior that maybe I don't want to go here, or maybe I don't want to go to that hospital because something happened to that particular person there. Mm-hmm. So these are things that we're going to have to confront as a healthcare community, that we're going to have to own that and try to start to meet patients where they are and rebuild that trust.
It comes along, or being aware of these kind of issues come along with being knowledgeable concerning the physiology, the biochemistry, all of the things that we learned, the rote memory stuff. We've now got to incorporate these other variables into the treatment of that patient.
Yeah, unfortunately, we sometimes call those the softer skills mm-hmm. of caregiving, and in the old days, you and I used to talk about the art of medicine.
Right.
It had nothing to do with the tests and laboratory results. Right. It had to do with us being willing to meet a patient where they are, embrace their disappointment, and then try to find a way to bring them back to a place of encouragement and a place of promise that we're going to give them the best care necessary for themselves and for their babies.
So in the prenatal state and the delivery state, do you see any particular problems affecting black mothers?
We do. Part of it comes from the fact that our black pregnant persons oftentimes start their pregnancies with histories related to their past pregnancies, and sometimes those histories include having a baby early, mm-hmm. or sometimes those pregnancies included maybe having difficult circumstances at the end of the pregnancy that required them to either have a cesarean section or to have some sort of intervention. It's understanding what those issues are and addressing those issues from pregnancy to pregnancy that are going to be really important to making sure that we avoid those problems in a future pregnancy.
We often talk about the high-risk mother or the high-risk pregnancy. What additional steps do we have to take in paying attention to that mother and that baby?
So that's what I do.
Mm-hmm.
I'm an obstetrician gynecologist that went back to school and got additional training in what is called maternal fetal medicine. Mm-hmm. We used to be called perinatologists a while ago.
Yeah.
So we concentrate on this subset of patients in particular. And so what it means for us is, first of all, seeing them as early as possible in the pregnancy, really painstakingly going through their past history and their current health to understand what their challenges are going to be for the pregnancy. And then once we do that, creating a plan for success for them. That oftentimes includes more visits than a typical patient. It will also include us doing more in the terms of surveillance of the pregnancy, surveillance meaning usually ultrasounds that allow us to follow that pregnancy, its growth or lack thereof. Really making sure that if they have particular health systems that are under attack for some reason or compromised, making sure that team is expanded. Mm-hmm. So you bring in a specialist that can help out with that. And so you really have this comprehensive team approach to care that you don't necessarily see with the otherwise uncomplicated patient.
Mm-hmm. You know, and on the primary care internal medicine side, we see women who are early on in the pregnancy still have not shown up for that first obstetrician visit yet, and you know that early prenatal care tends to lack for a lot of reasons, but I guess we can't stress the importance of early prenatal care in this community.
You know, we're going to have to, well, I think it's going to take a village to make mm-hmm. this change. Mm-hmm. It takes the family members to start to encourage their family member that, hey, no, you really should get your prenatal care started because you want to make the best care possible. It also takes us making sure that every visit is a visit that is useful mm-hmm. and is not just
routine.
Yeah, in and out and listen to the baby and we don't talk about anything else and then I'm gone. And I hear that a lot of times from patients. Mm-hmm. The person only spent 3 or 4 minutes with me. Right. So we can do better. And once we start to show that there's value to those visits, our patients sometimes do a better job. I'll mention one other thing that has helped. You may have heard about the centering and pregnancy movement. And so that's a movement where instead of it being individual visits with one patient, there's a group of probably 8 or 10 patients that get together for their visits. They help collect the information for their visits in terms of weighing themselves and in terms of checking on blood pressure, but at the same time they get a chance to talk about what's going on with themselves. And sharing experiences can really be empowering for those patients. Outcomes are better for those small clusters of patients.
Yes, sometimes the information coming from a different source makes all the difference in the world in terms of patient acceptance and understanding. And I think we've seen that in group settings and other areas of the practice of medicine also.
Absolutely.
But being the expert that you are, how do you really classify a woman as high risk? I mean, the general lay public, a lot of times it's just her age, but what should we really be looking at to classify a woman as high risk pregnancy?
If that individual has a past history of a poor outcome, that is automatically puts them in that camp. If that person during the pregnancy develops certain conditions like having problems with their blood sugar control or having problems with controlling their blood pressure, that will advance them into that group. If their baby, when we do our ultrasounds, is noted to have some problem that we identify by ultrasound, or the growth is not sufficiently robust, that puts them in. So there's a lot of different reasons that you can become part of that group, and it can be fluid. So we do have patients that start off being in a high-risk designation, but then things change and they're able to move back into the general population of obstetrical care.
So they're reclassified as being normal and an expected normal delivery?
Absolutely.
Okay. So what warning signs should moms be looking for? They're newly pregnant, not knowing that they're high risk or not, but should they be looking for certain signs and symptoms?
Yeah, I think your viewers will start to see that when they go to obstetrical offices, they're much more likely to have things, infographics and things on the wall that talk about this sort of thing. But when you have things like a bad headache, doesn't seem to want to go away with Tylenol rest, blurry vision, having problems with new onset swelling that you can't explain what's going on, any sort of bleeding during the pregnancy is obviously something that makes us very concerned. Any chest pain could make us very concerned as well. And of course, if there's any sort of loss of movement or absence of movement, those are all good reasons for you to go, wait a minute, somebody needs to check on me to see what's going on.
Very good. We're up against a break, Ted, and we're going to be right back after this short break.
In the 85 years of the American Diabetes Association, we've had many wins, but we've never rested. Because 1 out of every 10 Americans has diabetes, and they rely on us every day, just like we rely on you.
Welcome back. We're here with Dr. Ted Jones, Director of Maternal Fetal Medicine at Corewell Health. Dr. Jones, you mentioned earlier something that we need to, as practitioners, need to be incorporating into our interaction with patients, and one of them is how they're being treated and perceived, and not just in high-risk pregnancy, but in a lot of areas of this profession, we find patients feel that they're not being listened to. How do you address that? How do you incorporate that into the teaching, the trying to achieve outcomes with high-risk pregnancy?
Well, one of the important things is to linger and allow the patient to tell you what the journey was like in their delivery. So I'm not always at every delivery for my patients, but they will tell me that they didn't have a good experience. And then I look at the chart, and things worked out well in the sense that we avoided death. We may have avoided serious, a term we sometimes use is serious maternal morbidity. But the patient's experience wasn't a good experience. And then you find out that there were things along the way that the patient tried to bring up, they were feeling or experiencing, and for whatever reason, no one seemed to stop to really listen and to address that problem. And so even though you may think that you helped them avoid death or a serious injury, you actually imparted on them a pretty significant trauma that they're still working through.
Mm-hmm. So stress is always an issue. It's always a conversation. You know, we downplay it sometimes because it's so prevalent, but experts talk about it having a real effect on disease states. And I think a lot of the literature right now is pointing to that from many standpoints of view. The concept of weathering, though, the things that we've suffered through our lives that actually can reduce our longevity and add to the incidence and development of disease, seems to be one that would even be more pinpoint with pregnant moms.
It does, and it clearly is about the fact that over time, the slights and the experiences that that Black pregnant persons experience really accumulate, and they accumulate over time in a way that causes them to have greatly increased levels of stress. The consequences of stress, as we know, changes your metabolism in ways that can be harmful to that developing pregnancy. And those things in combination are the things that help lead to outcomes that are far below what we really want them to be.
You know, in other aspects of life also, I distinctly remember being in a family reunion years ago where people were talking about the people who had attained a college education had children that attained a college education, clearly distinct from other people who had not. So that factors into the experience that a mom may have had prior to becoming pregnant, during pregnancy, immediately after 1 or 2 or 3 children. All of these things factor into this and definitely has an impact on outcomes.
So the irony and the great segue for this point to make is that the outcomes for a college graduated Black woman in comparison to a white woman who completed school up to high school but not beyond are actually not as good as that white woman's experiences. So you can be a person with a college professor and very accomplished, but your outcomes are not going to be better than the person who completed high school, was not able to go beyond that, which means that there's an awful lot of negative impact even on that highly accomplished Black person compared to a white person because of the society that we live in and the experiences that they have on a daily basis.
As the kids say, a lot of stuff going on.
A lot of stuff.
Yeah, okay. So basically, we need to be able to collect this data. We need to be able to analyze it properly and hopefully come up with some solutions that make a change in terms of outcomes for this particular segment of the population. But chronic stress is always an issue no matter where you find it. And I tell people all the time, you gotta learn to deal with it. But something like this is hard to deal with if it has a historical perspective and can affect the mother and the life of the baby.
Well, it's not made any better by the fact that many of our patients are struggling on a daily basis. They have issues of food insecurity. My patients come back to visits and you realize that they had utilities turned off since you saw them last. They can't really get to where they need to get to for employment because they have no transportation. These things are additive, and the more we can do to help them overcome some of these effects on their lives, the better the outcomes are going to be for the pregnancy.
Let's shift gears for a second here. We hear more and more about doulas in the community that assist the whole process of labor and delivery and prenatal care. Explain their role and the effect that they've had on the outcomes.
It can sometimes be a daunting task for a patient to have questions and have concerns and feel empowered to ask about them and to make it known to us that they're uncomfortable with something. So having someone in that room, either a family member or a person who's a pregnancy support person, like a professional doula, like a person who is just say a midwife, can really be important for that person being able to be heard, helping them have their voice return with some sense of advocating for themselves, some agency. All of those things help that person have a better overall experience. Here's the challenge. We as caregivers, and especially physicians, sometimes we don't like people pushing back on the things that we have said or the things that we have suggested, and asking the why questions and asking questions about, well, how often has this been helpful, or how often has it led to complications? So we're going to have to grow as well as a profession to be willing to have an additional person on the team in that room asking those questions, and be willing to answer those questions truthfully and in a way that allows that patient to feel more comfortable with what is going on.
Sometimes you need to readdress situations again, and as I was mentioning earlier, sometimes it's better received if somebody else is delivering the message, okay? And we find that a lot of times in support areas that we have to provide service with patients. We were mentioning women who develop gestational diabetes, and understanding that from people who have gone through it, and not just the doctor, okay, themselves, and helping them understand that, hey, down the road, this might become a real problem for you. In other disease states also, we've seen diseases come out during pregnancy. We've seen diseases go away and symptoms get better during pregnancy also. So it's more of an educational thing that we have to look at in terms of helping people understand all of the variables around this thing called mom and baby.
Understanding that pregnancy is just one phase of that pregnant person's life, their health life. And so the more we can do to help them not just have a healthy pregnancy, but to be in the best condition possible when the pregnancy is over, to continue care, the better the outcomes are going to be. For instance, as you've already mentioned, if you develop gestational diabetes, it will almost always go away. But 70% of those individuals are going to develop diabetes.
Is it that high?
At some time in their life.
Wow. Okay.
Yeah. It's an eye-opener. And if you leave that pregnancy not understanding that, then you don't realize what you're monitoring for later on, or not monitoring for.
You recently moderated a conference, RX Kids program, which I wasn't there, but I've just been getting this great feedback. Tell us about that.
Yeah, we had a panel discussion where we discussed about aspects of maternal care and maternal child care. And one of the presenters, Dr. Monahana, talked about this new program in Flint, Michigan, but now has spread actually across the state.
Yes.
And so what you're finding is that if you give support to the patient during pregnancy with cash assistance, and then continue that cash assistance beyond pregnancy during the first year of life, you're doing the thing that we talked about from the very beginning. You're actually doing something to affect their poverty level. And when that poverty level is treated in a proactive way, things are better. You're not having utilities lights cut off. Right. You're having opportunities to be able to find childcare. You're having opportunities to avoid the food insecurity that we talked about earlier. And outcomes are better. Now, it's early for us, but this has happened in other places around the country and even across the world with good success.
Good success. But you can't get to the point of a presentation like this without a lot of work and behind the scenes activity. How long was this in the making?
My understanding is that they have been talking about doing this over the course of the last couple of years, and finally got the will and determination to get the monies to be able to do it.
Where did the funding come from?
Now that I am not entirely sure about in terms of where it came from, but I'm almost positive that it was a partnership between city and county government to put that together.
But it was funded.
But it was funded.
Right. Most good ideas require funding.
You can't.
I mean, we can be the world's greatest volunteers, but our success is limited until we have considered the financial aspect of any of these ideas.
What do we say? No money, no mission.
No money, no mission.
Yeah.
No ticky, no laundry. You know? What do primary care providers need to know and be aware of surrounding this issue of high-risk pregnancy and pregnancy in general? Because a lot of times, primary care doctors say, "Well, just punt to the obstetrician," you know. I mean, but there's a role that we play also in advising these patients and assisting in terms of successful outcomes.
Absolutely. So the important role that primary care providers make is their awareness of the fact that this person is a reproductively capable person. And as long as they can have a baby, we need to think about that. Think about that in what we're prescribing for them. Thinking about that in terms of what testing we would suggest for them. And also think about helping them plan their pregnancies. So reproductive planning is family planning, as we sometimes call it, is really important. It's not just the purview of the obstetrician gynecologist. They want to be thinking about that because the medications you write for may have an effect on the contraception that was prescribed for that individual. So keeping all those things in mind, it really allows us to really do a better job in care. The last thing I'll mention is a concept that we really want to do more of, but we just don't always have the request to do it, and that's something called preconceptional care or pre-pregnancy planning. So sending a patient before pregnancy to an obstetrician or a maternal fetal medicine specialist who can kind of go through their entire history and understand where they are and what the risks are for pregnancy and what the opportunity is for success. Those pregnancies almost uniformly have a better outcome.
Funny you should mention that. Is genetic testing part of that?
It is. It is. If we identify patterns of disease in a family, it allows us to then start to use prenatal testing in an affirmative way that allow us to identify things that might help them make important decisions as a family.
Very good. Dr. Jones, this has been outstanding. Thank you so much for joining us, and we'll have to do this again.
Look forward to it.
Good. Thank you. Our guest today has been Dr. Ted Jones, Director of Maternal Fetal Medicine at Corewell Health and Chairman of Michigan State Medical Society Task Force for Advancing Health Equity. The health of black mothers and babies remains one of the most urgent challenges in our communities. Real change will require great awareness, better care, and stronger support for mothers and families. For Primary Care, I'm Dr. Lonnie Joe.